All right, so let's talk about seizures. So what chapter is it? It's chapter 59 called Chronic Neurologic Problems on page 1419. So seizure, epilepsy is reoccurring seizures. So epilepsy is only if it's only called epilepsy if it's 2 or more seizures. All right, let's talk about the causes really quickly. So the causes could be metabolic disturbances just for a seizure in general, like acidosis, electrolyte imbalance, hypoglycemia, hypoxia, dehydration, water intoxication, alcohol, barbiturate withdrawals. That's all of like the underlying problems that could be. There's extracranial seizures outside of the brain, hypertension, your SLE, remember systemic lupus erythematosus, diabetes mellitus, septicemia. So these are extracranial reasonings. Many of these seizures could be idiopathic. The cause is unknown. There's specific types when it comes to inside of our brain, like generalized focal seizure, febrile. So generalized, focal, and febrile are our main types. There is also psychogenic when someone's faking it, basically. There can be a genetic factor, but most of the time it's idiopathic, and the cause is unknown. There's also, if it's a seizure like epilepsy, gliosis, which is like scar tissue around the nerves, change in function, astrocytes is basically theorized that it can cause seizures to reoccur. Okay, so let's just talk quickly about the age of the differences to be aware of. So like after age 50, the cause could be tumor or stroke, which is both of our exemplars, by the way. So brain tumors, stroke, both exemplars know them. 20 to 30 is our structural lesions, vascular disease, brain tumor again, which is one of our exemplars. 2 to 20 could be like our birth injury, infection, trauma, genetic factors. That's where we're really focusing on this epilepsy, this reoccurring thing that's associated with children a lot of times, or birth. 6 to months or younger. So this is just giving us a vague idea. The birth injury, severe congenital birth defect involving the CNS, infection, inborn errors in metabolism. So a basic understanding of what is going on. So that's everything for just the causes, and it's pretty self-explanatory. All right. So we're going to talk about the clinical manifestations, like what are we going to see in our patient, how are we going to assess the patient, what are the diagnostics to make sure and it confirms, what is going to be the complications that we should watch out for, and what are our interventions. That is what I'm going to cover today for seizures. All right, so there's different categories that I want to get into your heads. We got our febriles, that's our children. Usually it's a transient thing, like transient for childhood. We got our psychogenic, so like people are faking it because, well, they had some traumatic psychological thing and they just, I don't know. It's basically a pseudo seizure. And there's ways to figure that out, maybe in the EEGs or some diagnostic testings. There's a focal seizure happening in a focal place. Focal, like focused, focus your microscope. So focal seizures, there's phases of the seizure, which is not a type of seizure. I'm just saying that there's phases of seizures and that you should know like the difference. Knowing about the phases helps you know if some of them have automatisms, basically things that happen before the seizure even occurs. There's generalized also, so meaning the whole brain. But the reason it's so important to know is because if you're going to think about surgery, let's say, a generalized one, how are you going to have surgery? It's all over the brain. Yeah, not going to happen. So it's very good to know if you're a candidate for surgery. If it is a focus seizure, you may be a candidate. Things to think about. All right, so I was going to talk real quickly about all of these because I don't get much time on my phone as time limits. Okay, so febrile. As I discussed earlier, it's a trial transient disorder. For these, we're going to want to think about giving our acetaminophen, ibuprofen. I know I shouldn't be talking about interventions yet, but that's just what happens. For some reason, there's no tepid baths. Not really sure why. Maybe to avoid them from shivering. I don't know. Protect them from injury, just like all the rest. Rectal diazepam and diazepam gel is if second seizure is very likely, then these are things that they'll prescribe. All right, so then there's psychogenic. This is what we know as our pseudo-seizure. Use a video EEG to make sure that that's not happening. All right, so for our focal seizures, focused in our brain, or wherever it is, depends. What are we going to see? Oh, I didn't even talk about the phases yet. I'll get there. It'll make more sense then. All right, so focal, complex seizures. We got two types of focal, complex and simple. Complex, we're going to see display of strange behaviors, lip smacking, automatisms, which is like repetitive movement. Retrograde amnesia, it's not daydreaming. That is how you differentiate. So it's not daydreaming. That's how you differentiate from our absence. So lip smacking, automatisms, repetitive movement, retrograde amnesia, it's not daydreaming. Okay. For a simple, it's a little bit different. So our simple is the sudden and unexplainable feelings you may hear, taste, feel, or see things that are not real. Psychic symptoms, recurrent muscle contractions, abnormal sensation of hallucinations, tachycardia, flushing, and hypotension or hypertension. All right, let's keep going to get our differentiations out. All right, so let's talk about our phases before we even get into this, because that's kind of important now. Prodromal phase is the signs that precede the seizure. Prodromal precedes the seizure. Oral is that sensory warning, like ambulance. Think ambulance. Prodromal precedes, oral, ambulance. So you're sensing it's coming really soon. Ictal, active. There's not really a way to remember it. Post-ictal is the recovery after the seizure, and muscle aches and headaches or confusion can result during that time. Okay, hold on. All right, so there's different times to generalize. So remember our whole brain. Okay, so we got our myoclonic, our atonic, our clonic seizure, our tonic seizure, so those separated, absence seizures, and tonic-clonic. So our absence also has two types, typical and atypical, and we'll talk about that. Oh, that's a lot of information. Okay, so myoclonic, let's talk about that real quick. That one is myoclonic. It can be forceful enough to cause a big fall. So you want to think of traumatic hand injury risk for that one. It's going to be excessive jerking. Our atonic is like A for nothing. You know, A means can negate the whole thing. So atonic, a sudden loss of muscle tone, consciousness returns by the time you hit the ground. So it's very fast. Our clonic seizure is a little bit different. It begins with a loss of consciousness, sudden loss of muscle tone, limb jerking, hyperventilation, eye roll back, and frothy at the mouth. So it's not so easy to remember that, but just, I'll say it one more time. Begins with a loss of consciousness, sudden loss of muscle tone, limb jerking, hyperventilation, eye rolls back, and frothy at the mouth. Okay. Then our tonic is a sudden increase in tone, tonic for tone, incontinence, breathing sensation, so because it's toned, cyanosis, fixed dilated pupils, and fall. Okay, so what is our tonic-clonic now? Our tonic-clonic happens about 10 to 20 seconds, and clonic happens 30 to 40 seconds. You're going to have excessive salivation, tongue cheek biting, cyanosis, fall to the ground. So it happens in different stages. Now, it's second generalized. If you see a Todd paralysis, this is a focal weakness. And if it's preceded by oral, this is generalized secondarily. So if you see oral, like oral is the sensory warning signs, it's a secondary generalized. If you see focal weakness, it's a second, which is called Todd paralysis. It's a secondary generalized type. So for absence seizures, and I'm going to want to review that more for the paralysis, the secondary generalized type, because that's kind of interesting. It's a little different. So absence seizures, there's a typical and an atypical type. For our typical, the children rarely beyond adolescence, they cease with maturity usually, or develop into another type, the precipitation. So big thing to remember is our flashlights, maybe even like video games, because that's like lights, and hyperventilation can also trigger this. So that's the big thing to remember. Typical can be often unnoticed, maybe 100 times a day, blinking like this. Really fast? Okay. Fluttering, automatisms, which is, automatisms is those repetitive Movements, like I said before, precipitated by hyperventilation, lights, staring spells, daydreaming. So that was different from the, I think it was the symbol that said something that was different, that it said retrograde amnesia. It's actually the complex one that says retrograde amnesia, not daydreaming, and that's how it is differentiated. Okay. So then we have our 3 hertz per second EEGs, the spike and wave pattern. So specifically typical is like that 3 hertz you'll see on the EEG, spike and wave pattern, which is very different from atypical. Atypical, you're going to see that spike and wave pattern on the EEG is going to be, it could be greater or it could be less. It doesn't make a difference. And they're going to have staring spells with other signs and symptoms. They may have a brief warning, peculiar behaviors during this time, confusion is going to happen afterwards, and there's going to be a longer lasting and lost a postural tone. So it's a little bit different. All right, so that's all our clinical manifestations. Let's talk real quickly about some of the diagnostics. Now, mind that not all seizures have the same causes, so some of them are happening within the brain and some of them are extracranial. So that's why you want to rule out the reasonings. Like, we're going to look at the liver, we want to look at the kidney function, we want to have a urinalysis, we want to look at the comprehensive assessment, our CBC's, complete blood count, metabolic chemistry, because at this time we don't know the reason. Cerebral angiography, PET scans, MRIs, CT scans. CT and MRI is going to rule out a structural lesion, because that could be also an underlying reason. Now, we also want to look at cerebral angiography, PET scan, MRA. A megaencephalography may have greater sensitivity, but the common one you want to think about is our EEGs within that 24-hour time period. So, like, EEGs should be done within 24-hour time period of that seizure. So you may not have normal. You may have a normal EEG, so it's not like a definite. Okay, let's talk about our complications real quick. So some of our complications can honestly be just severe injury and death, which is not good, and that's what we're trying to avoid. So that's why safety is like a huge thing in seizures. Psychological therapeutic communication, because they may have driving sanctions, employment limitations, social stigmas to this. So our big thing that we want to think about is this thing called status epilepticus. Tonic-clonic is the most dangerous type to have this happen. It's an emergency. Lorazepam is going to be our first response, diazepam, IV bullets, rapid stuff, basically. There is such a thing as a subclinical seizure, which is sedation without external signs. So you're not going to see the external signs, but they're having a seizure because of this sedation. And then the last thing is also there's a thing called a sudden unexplainable death of epilepsy, which is scary, but it's called SUDP for research purposes. All right, so what are some of the things? Well, obviously nursing management. So whatever our immediate interventions you want to think about is you want to establish an IV, you want to protect from injury, especially head injuries, padded side rails, do not restrain the patient by any means, maintain a patent airway, ensure the ABCs, airway, breathing, circulation, loosen the clothing, all that. I want to do this before we get to, I want to do all the interventions before I get to pharmacology specifically. So for surgery, we're going to want to think about if there's no satisfaction with drugs, and there's a defined electrical clinical syndrome, which you know the focus point. That may be, they may be candidate, you don't know. So there's anterior temporal lobe resections and stuff like that. So but you have to really know what the diagnosis exactly is. To do that, if they're not a candidate for surgery, there is an alternative. It's called vagal nerve stimulation. But there is things you have to teach that patient. Like teach them to avoid MRIs and microwaves. They're not going to know if you don't tell them. So you got to make sure to teach the patients no microwaves, no MRIs for vagal nerve stimulation. Other things to be mindful of is that adverse side effect of for vagal nerve stimulation is the cough, hoarseness, dyspnea, tingling at the neck. And I'm going to have to do more research on it to see what this is all about. Especially also this ketogenic biogenic feedback. So it says it's basically a high-fat, low-carbohydrate diet. I need to do more research on it. If there's a reason, they may not know why. So sometimes that happens in medicine. But there may be a reason, so I'm going to go check that out. So if it says in my notes, so if the patient has anticoagulations, then they have to teach to watch for bleeding. And so I'm going to have to do research to find out why, because I don't know. Okay, so now that we know all of that, we can get into pharmacology. So some common ones is like pregabalin, which is broad spectrum. Gabapentin. Okay, so broad spectrum we get gabapentin, lamotrigine, topiramate, tigamin, levetiracetam, zonisamide. So there's a lot. And then there's specific ones like phenytoin. I'm going to have to do more research in the Lenny's textbook for this. This is kind of interesting that there's so many drugs that are so different. Phenytoin, you want to think of that peeling rash, hyperplasia of the gums, hirsutism in young adults. There's carbamazepam, phenobarbital, Vilapro X pyramid. With absence, there's a thing called ethosuximide, Velaprox, clonazepam. So just know there's a lot of drug types, and there may be a chapter in Lenny's textbook, and I would do like a whole video on that if I have time. Okay, so one of the things is how are you going to act with status epilepticus? So follow by long-acting. Oh, no. First thing, you want to make sure they give them the lorazepam, the diazepam, intubated maybe, possibly, EEG continuous. Children may need general anesthesia and followed by long-acting anti-seizure drugs. Also, they may need to be weaned off at seizures, so free for 2 to 5 years of seizures, they may be weaned off. You do not want to stop abruptly. There's a big fall risk. Monitor for dizziness and drowsiness. So also other things to know for like teaching considerations for a nurse. If a dose is missed, wait for the next dose. If a dose is missed, wait for the next dose. Common side effects is diplopia, drowsiness, ataxia, mental slowing. These are just common in general for anti-seizure medications, though. Toxicity would be nystagmus, hand-eye coordination, cognitive functioning, general alertness. I want to look more into this drug stuff, actually. This is good that I'm studying with y'all. All right, so for older age, you want to think about monitoring their liver function, especially with phenytoin. What is safer for older adults? I have in my notes, it's gabapentin, levetiracetam, oxcarbazepam, lamotrigine, phenobarbital, carbamazepam, primidine, effects of cognition. Okay, so there's all these drugs, and I think the main thing to take away from this is know how to assess for the seizure. How are we going to react to that seizure? Because there's obviously certain medications to help with certain kinds, but for status epilepticus, there is protocols. So there's a lot to learn, and happy studying. This was about seizures.